paper studying the use of virtual reality during medical procedures for children. Virtual reality, VR, is a low-cost, adaptable intervention that can be used to distract children during pediatric procedures. This intervention is both versatile and promising, having been used in clinical practice to safely and effectively alter the perception of anxiety and pain experienced during various medical procedures. The effects of VR on pain and anxiety during blood draw have been investigated in 10 to 21-year-old healthy children, with results showing it to be a successful deterrent from procedure-related pain and distress. Similar results were found when using VR during intravenous procedures in pediatric patients with chronic disease. However, these findings are not generalizable due to limited studies pertaining to the effects of VR in younger children and on the outcome of fear, which is associated with pain and is present in higher levels in children of younger ages. It's also possible that children respond differently to different types of VR interventions. The study examined uses a younger age group in 2 different virtual reality interventions and as well assesses fear with the aims to address these gaps in literature. Thus, the author's objective was to determine the effects of virtual reality on procedural-related fear, pain, and anxiety in 5 to 12-year-old children undergoing blood draw. The authors use a prospective randomized controlled trial with 3 groups: 2 virtual reality, one simulating a roller coaster and the other an underwater marine tour, and a treatment as usual control. Choosing an RCT was the best choice as it allows for inference of cause and effect should the association between the variables be significant. 141 eligible children meeting the inclusion criteria were assigned to a group by computer-generated block randomization. This reduced the selection bias, ensuring groups are as similar as possible. The researchers were blinded to the randomization process and thus did not know which groups the children were in, eliminating both observer and confirmation bias. They hypothesized that children in the virtual reality groups will have significantly less procedural-related pain, fear, and anxiety as compared to those in the control. Pain, fear, and anxiety scores were measured using 3 validated scales before and after the procedure. However, these scores were self-reported, carrying a risk of social desirability bias. The reliability, however, of the results is increased as results from multiple people were reported, including children, parents, nurses, and researchers. The authors collected data using various statistical tests. A one-way ANOVA was used to compare mean scores, and post-hoc pairwise comparisons determined any statistically significant differences between groups. Kruskal-Wallis analysis was used to compare pain scores, and linear regression analysis evaluated fear and anxiety. However, these tests were not adjusted for covariates such as age and sex, which may observe the outcomes observed. The authors found significantly lower pain scores in the 2 virtual reality groups compared to the control. No difference was found between the 2 VR groups. These findings support their hypotheses as both VR interventions successfully reduced pain, fear, and anxiety in children ages 5 to 12 during blood draw. There was a significant positive relationship observed between fear and anxiety point differences in both virtual reality interventions. However, a significantly negative relationship was found within the control group. The VR Ocean simulation reduced anxiety at a level of 2 times greater than that of the roller coaster VR group. Thus, the authors especially recommend the use of Ocean virtual reality during invasive procedures. Based on these statistically significant results, the authors conclude VR to be an effective intervention in reducing pain, fear, and anxiety in 5 to 12-year-old children during blood draw. Because virtual reality was proven to be effective in younger children, these results are now more generalizable to those of younger ages. Multiple people assessing the outcome of interest as well as computer-generated block randomization further credit the success of VR. However, limitations do exist. This includes the relatively small sample size and inability to generalize the results to children of other ethnic backgrounds. Additionally, the children, parents, and researchers assessing the outcomes were not blinded to each other's results, creating the possibility of bias. Younger children and those with more painful conditions carry a greater risk of experiencing pain and fear, but were not included in the study. Additionally, none of the participating children had prior virtual reality experience, which may have led to greater reductions in the outcome of interest due to the novelty in such intervention, and thus may not be generalizable to those already accustomed to VR. The authors cite a few recent studies whose findings are consistent with their own. For instance, virtual reality was found to decrease pain and fear in children receiving immunization. VR was also found to reduce pain levels in hospitalized patients in children ages 7 to 12 undergoing blood draw. Those studies with contrasting results are not cited or mentioned. The authors note the lack of comparative studies available due to the novelty of their own. Overall, this study provided significant results demonstrating the safe and effective use of virtual reality in reducing pain, fear, and anxiety during pediatric blood draw, supporting the author's hypothesis. This study contributes novel information in the field of healthcare as the outcome of fear in pediatric patients of younger ages had not yet been analyzed in previous literature. It is for this reason we believe this study, conducted with scientific rigor despite its few limitations, is of importance. The authors advise for the use of virtual reality in healthcare settings, particularly for children undergoing medical procedures. Their results have the potential to inform clinical practice in which evidence-based guidelines pertaining to the use of non-pharmacological treatments such as virtual reality should be established.